Okay, good morning. Good morning, respected chairpersons over in the seminar room. So today now we will be starting the live telecast of the VATS 3 incision esophagectomy. So I would like to introduce our team. Myself, Dr. Binay, Dr. Sagar Khatibara, he is also the executive member of the Nepalese Association of Surgical Gastroenterology. Dr. Manoj Tiwari is here with me. And also I would like to introduce our nurse, Mrs. Hamal. Sarita Hamal is here. The circulating nurse is Namrata sister and Raksha sister. And in charge, OT in charge is one of the OT in charge is there with you, Mrs. Manju Baral, and another OT in charge is here, Mrs. Kopila Khadka. And same way I would like to introduce my residents also. Dr. Ashish is here, Ashish Kharel. Dr. Sandeep Sapkota, one of our registrars is there. Perhaps Dr. Sachi Bhatra is there in the room. And also Dr. Mahesh Mani Adhikari, he is also sitting in the room. In the same time, I would like to introduce our anesthesiologist team. We have done a very good job. Dr. Yogesh, he has gone somewhere out. Dr. Yogesh, Dr. Rasmit Hapa, Sumit Singh is the anesthesia technician, and Kiran Bhai, I think Kiran is also gone out somewhere. And also we have the several staffs here over the OT room. So now we'll be starting in a moment. I would like to introduce about the case, discuss about the case. Dr. Ashish, please talk about the case. Just in summarize about the case, today's case.
Okay, thank you, sir. Just give me a moment.
Hello?
Good morning, everyone. Today's case is a 41-year-old male from Rupandehi, and he presented with history of hematemesis 9 months back. So the patient is a 41 years male from Rupandehi and presented with history of hematemesis 9 months back and progressive dysphagia. On presentation, he had grade 3 dysphagia of 5 months duration. He is a past smoker and does not have any chronic illnesses. So, after presenting in our unit, but he was evaluated with OGD, which revealed a growth at the distal esophagus. Biopsy revealed a well-differentiated adenocarcinoma. So, as per our protocol for adenocarcinoma of the esophagus, the patient underwent neoadjuvant chemotherapy and he received 4 cycles of FLOT4 chemotherapy. And the last cycle was 28 days back. So currently his general condition is fair, the weight and height are normal, the patient is an ECOG1 status, all the other systems are within the normal limit. His pre-op labs are essentially normal. The endoscopy after the neoadjuvant chemotherapy revealed some residual disease in the distal esophagus at the level of the cardia. So we are with the Cybert type 2, and this is the pre-operative CT scan. So as we see the axial sections, we can see the esophagus in the distal part and at the cardia is thickened. The circumferential thickening is around 14 mm, and we can see some periesophageal nodes also. There are no significant nodes in the abdomen. So with this history, clinical examination and findings, we are planning for VATS 3-phase esophagectomy, and I will go back to Binay sir for the procedure.
So hello, good morning. Dr. Robin. Dr. Robin, can we start? Dr. Robin, can we start? Am I audible? So I think we are going to start. Anyway, there is some sound issue, so we can show here. Thumb thumb. So Dr. Yogesh and Dr. Rasmi is here. And they are our anesthesiologist team. So with their help, we have intubated the patient, and also the patient has been kept first in the lateral position. Then we tilted the patient semi-prone. We have tilted the bed to 45 degree. Can you go ahead a little bit back? Yeah, 45. So patient is lying in the lateral position. Then we have done to the semi-prone position by tilting the position of the table. So this is the tip of the scapula, we can see here. This is the head end, this one. This is the foot end, downside is the foot end. So I have just made a simpler marking. This is the tip of the scapula, so generally it corresponds to the 7th intercostal space. So we'll make first 10 mm port here for the telescope, and then we'll make the another 4 fingers above. It will roughly correspond to the 5th intercostal space here, and 4 fingers below it will roughly correspond to the 9th intercostal space. These two will be the 5 mm working ports. So we'll work with this. So we'll start now incision. So the instrument setup, we can see we have put the instruments over the right side, here the head of the patient, and the telescopic camera is here in the left side over the waist of the patient. And this is the nursing station. We have kept very well everything. So today we have been working with this Gen 11 instrument from Johnson & Johnson. People from Johnson & Johnson are kind enough. Thank you very much for providing us with this instrument. So to be using this instrument. We have few instruments only. We can do the thoracic part without this instrument. We can do only with the so we can do with the hook and the bipolar as well in the thoracic part. But we start now. So now give me the knife, please. Can we start, Dr. Yogesh, Dr. Rasmi? So we'll start now. So I have forgotten to mention we have got also our floor attendant, Dharma sir. Yeah, so I think he's missing. He has gone. The Tyson sister has also come. Other sisters have also joined us. So we'll start now. Kiran Bhai is, I'm not seeing Kiran Bhai, so I think he will be joining us later on. So I will first make the first incision over the 7th intercostal space, this one. So about 10 mm port I will make here. Like Kelly the glass piece. So I'm just like putting the chest strain tube. So I'm inside we have intubated the patient with a single ligament tube as we do routinely. I mean, we don't keep the double ligament tube. So there is 10 mm trocar I'm inserting inside. Just gently. We can do this with the varus needle insufflating the pneumothorax, but we have skipped that step. So now we will join to the CO2 pneumothorax. We are creating the CO2 pneumothorax. The pressure will be kept at 8 mm of mercury, and the flow rate will be about 6 liter per minute. Gas on, please. Ribbon gas, ribbon gas. So it is our routine habit to clean the port before inserting the telescope, because there will be some blood contents which will obscure the vision. Gas on gardenu na. Pressure chahi 8 मा राख्दिनु 15 मा हैन. Okay. So may I request Professor Robin Koirala, he is the president of Nepalese Association of Surgical Gastroenterologists, to moderate the session. Hi Dr. Robin. So we have started here. So I would request you to moderate the session over there. What? Started? Gas van. Gas. Hello? Yes, Dr. Robin. So we have just kept the telescope. Or can we request you to moderate the session? start. One. Yes, yes. That. So we are starting the case, Dr. Robin. Yes. Yeah. So now I will put the second port. So we have created the CO2 pneumothorax. So now I will put the second port here. Knife then. At the fifth intercostal space. 5 mm. 5. सफा गर क्यामेरा सफा गर नाइफ 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 So now we'll insert the second port, that is at the 9th intercostal space. Port. Go. So now we'll start the case. I have put the gauze piece over there because sometimes there will be the bleeding, so we can gas ko issue हेर्नु कुक दिनु तो अर्को चेन्ज गरिदियो हुन्न ग्यास को कसैलाई भनेर कि अर्को के एकछिन मनोज Sagar. So I will introduce with the anatomy of the lungs here. Go ahead. Sagar. So I will introduce. This is the head end of the patient. We can see here very clear. This is the esophagus vein is here seen here. This is the superior going. This is the superior vena cava. This is the phrenic nerve. The subclavian vessels are here. So now next we can see just a bit out. So we can see here. This is the bronchial trachea. This patient has got the high insertion of the esophagus arch. This we can see the esophagus is here. This is the lung I am retracting, and to the foot end we can visualize here is the aorta, and this one is the diaphragm. So now we'll start with the case. So I'm using with a 5 mm port here. I just retract the lung like this. Then I make go in place, and I just start with the first incision over the infraesophagus part. Sorry. Go. So go ahead. So you see, he has got some anomaly perhaps because the esophagus is lying quite high. Because I can see. So port placement, I will repeat it again. Can you show, Dr. Sagar? So here you can see this is the tip of the scapula. So corresponding this will be approximately 7th intercostal space. So that would be the first telescopic port 10 mm. Yeah. So this approximately would be mid-axillary. Now thereafter 4 fingers above, this will approximately correspond to this my index finger to the 5th intercostal space, and 4 finger below is the another 5 mm port, that is approximately 9. So 5, 7, 9, 3 ports in the semi-prone position, 2 5 mm port, working port, and 1 telescopic port. So now we begin. Go in please. Yes, so now I said that this patient has got some anomaly because esophagus arch is quite high, because this is the trachea, this is the right membrane, because the carina is somewhere here. We can see the subcarinal lymph node. So this esophagus arch should be at this location, but he has got higher location of the esophagus arch. Anyway, I start with the infraesophagus dissection first. So I make incision. I should have made the incision here, but since the esophagus arch is high, so I will make here incision somewhere. So I'll pick up the cortical hook with the pedal denter. So I will make a nick over the mediastinal pleura interior to the esophagus. This is the esophagus, so interior to the esophagus I will make a nick. I can visualize very well the right vagus nerve also. I just lift slowly the pleura. Go in please. Yeah. So I can just gently lift it and make a cut over the pleura and go gradually. I move downwards till I reach the diaphragm. Just a moment. Go in please.
There's another question. How often do you get anomaly of right or zygous vein?
I have never seen my practice. Anomalies we can see, but so high location insertion of the zygous vein, I have to check in the literature. So far, I have not noticed, I have not experienced any time. So high insertion of the zygous vein at the level of the trachea, mid trachea. Wait. So I'm gradually moving downwards. Here we can see this the lower lobe of the lung. So that should be the inferior pulmonary ligament, because this is the diaphragm. This is the attachment of the lower lobe to the diaphragm. This is called the inferior pulmonary ligament. So I need to divide the inferior pulmonary ligament. So we are going in. Okay. This is the inferior pulmonary gas on garden, gas further. So I will go a little bit more. So our principle is also in a case of malignancy to do the mesoesophageal excision, right, like in the mesorectal excision for the CA rectum. So we remain a little bit far away from the esophagus, because you can see the esophagus is here. I'm taking the tissue a little bit, about 1 centimeter I would say, at this location. At some certain location we can remain closer, but wherever it's possible we can go a little bit farther. So here now I'm gradually, these are the flimsy blood vessels. So I welcome our Murra sir. He is Dr. Tej Kumar Gautam. He has just arrived. He is a great ENT surgeon. I think many of people you must be knowing. Can you show his face also? Dr. Tej Kumar Gautam. He was our previous director. Thank you, sir. So now we move forward. We can see some of the structure. This is the inferior pulmonary vein. Okay. So now we go ahead. This flimsy blood vessels we can just coagulate with the cortical. Here we should notice here. So we can see this is the main branch of the vagus nerve, right vagus nerve, this one. So there will be the sum of the branches going to the bronchus, this one. So we want to preserve those vessels, those nerve fibers. So I go closer to the closer to the esophagus in order to preserve the main trunk. So I can cut here. Go in, please go in. So is the vision clear over there in the hall? So I'm going a little bit slower today. Ask this. Can you ask if the resolution is clear over the hall? Some issue, any issue? Okay, go in please.
Vision is clear.
So I also would like to thank our authority, our chairman sir, our director sir, and also deputy director sir, and IT team, whole IT, Ibrahim sir and rest of the Utsav bhai is here. He has helped a lot to establish this system here. So I'm now, after making some of the dissection infrazygously, I will move to the infrazygus dissection in the posterior part of the esophagus, because I have made in the anterior part, so I move to the posterior part of the esophagus. So now I'm making similarly the pleural niche over here. Go in please. Go in little bit. Go in.
So there's a question.
Yeah.
Approximately how much should we trace the vagus nerve?
Proximally, it's you mean to preserve or to cut it? I didn't understand the question. So
Approximately should we trace the vagus nerve is the question.
proximally we can trace the silence the mobile. Proximally we trace the vagus nerves if you want. It depends upon the which type of the lymph node dissection you are going to do. So if it is simply the infracanal, it depends on the tumor location. Where the tumor located is type 2 G junction cancer, then there may not be any point in doing the supracanal lymph node dissection. It means superior mediastinal lymph node dissection. So at those points you don't need to dissect out all the lymph nodes quite high at the thoracic inlet. But if you are trying to dissect the supracanal lymph nodes or superior so if you want to dissect the supracanal lymph node, then you have to trace the vagus nerve as high as the thoracic inlet, because you need to clear off the nodes which are located at the right recurrent laryngeal nerve. So it depends upon the philosophy of dissection that So at this point of time, I routinely want to visualize where is the thoracic duct. Go in. So this is the azygous vein. Go. This is the aorta. So I will pick up the I'll pick up the pleura here, make an incision over here. The air is going in, so that we can visualize something transparent structure which will be the thoracic duct in between the azygous vein and the aorta. So in a moment we will try to find out. This should be the This is the thoracic. Can you see the thoracic duct?
We have got another question, sir.
Yeah.
How do we identify the thoracic duct and how to tackle its injury?
It's simple. You can see. Go in, please. So this is the esophagus vein. This one. This is the aorta. This is the esophagus, right? I have cleaned the the pleura, and this structure is very well seen. This one, transparent structure. This is the thoracic duct. So there are various ways to identify it also. So intraoperative, this is the simple way. You can identify. It's very clearly seen, right here. Everybody can see here the thoracic duct. So one of the other option, if you are not quite sure, in the case of injury for the thoracic duct, for some other reason like road traffic accident, then you can inject the ICG and identify it. So thoracic duct is very clear here. So at a later moment of time, you can just clip it, right? So I have made a space here for the future ligation of the thoracic duct. Is that clear? So I have made the thoracic duct very visible here. Okay. So now I go for the further dissection. Go in, please. This one. Go in, please. So far I'm working with the hook only. I insert my grasper here, so you can see the plane is opening by itself. So here could be some of the small fibers of the vessels coming directly from the aorta. We can buzz with the smaller diameter, we can buzz with the hook cautery only. Go in, please. There is a small node, this one, the small node along the thoracic duct. You can take it out or you can leave it, it depends upon you. So same, I'm gradually just moving slowly because there is a less chance of the error. If we make the error, we can make a hole into the aorta or in the major airway. So I'm going very slowly here. So you can again visualize a larger vessel here, this one. So at a later point of time, we can use the bipolar or the harmonic that has been supplied by us. Here we can see the contralateral pleura. Go in here. We can see the contralateral lung. Is it visible? This one is the contralateral lung. So I remain. You don't know, quite often what happens, you can open up the pleura in the contralateral side. I can see a small hole made in the pleura, but that doesn't make any difference.
So we have another question, sir.
Yeah.
How to identify the left vagus nerve?
Now I will show in a moment the left vagus nerve because we are now not going. So I have excised a piece of pleura in the contralateral side because the node is here. So I want to take out the node since the patient had got G junction type 1 tumor. So it is reasonable to take out the node. So I have opened this the contralateral pleura. This is the contralateral lung. There is no issue. You can insert another chest if you wish, or you may just leave it like this because this is the CO2. It will reabsorb in a moment of time. So this is the 110 lymph node group. Go in. Please. So go in, please. So I'm moving towards the diaphragm. Go ahead. Go ahead, please. Okay. So now we move to the other side. Sorry. Here. Put it straight. Yes. So I lift the esophagus like this, right? The esophagus is lifted. So this is the pericardium. Go in, please. So all the fibrofatty tissue is being cleared from here. So esophagus I'm lifting up like this. So this is the loose alveolar tissue, like in the rectum. We do in the work in the plane of Bill. So similarly, we work here in the plane of the mesoesophagus. So I'm clearly seeing that all the fibrofatty tissue, if the lymph nodes are there, will also clear taken up with the specimen here. Go in here. Go in please. Go in please. Right. Dr. Robin, if some comments you have to make, please, you are welcome. Going. So we can see there is some edema. This is after the chemotherapy because the patient has a floor regime for the CAG junction type 1. So we can see a little bit of edema. That should be the response to the chemotherapy. I can feel a tumor here by my grasper. Thank you, sir. So now I have reached to the diaphragm. Go in, please. Here we can see that we have reached the right cross of the. Sorry, just someone give me the goggles, please. Go in. Go in. Yeah. So you can see this is the right cross of the diaphragm. I will show you in a moment even better.
So Dr. Robin has another question.
Yeah.
Do you take a cuff of the diaphragm?
If the diaphragm is invaded, definitely. If that's not invaded, I don't take. You can see the cross is very clear here, right cross of the diaphragm. So if it is invaded, definitely we take it. If not, then only R0 resection is our goal. Whatever the extent of surgery required, you have to do. If the diaphragm is invaded, definitely we have to take the diaphragm. If not, I routinely do not take it. Sorry. Go in, please, here. Go in. A little bit in. Straight work. Straight work. Go in. So this we call is the mesoesophagus because we are taking each and every bit of the tissue on the bhitar gam. This is the contralateral lung, right? Okay, you can leave it here.
Fascia formation is very poor in this patient, I guess.
Yeah. So Dr. Sagar commented that the fascia formation is very poor. Can you comment, Dr. Sagar? Why did you say that?
Because the esophagus arch is also not plastered there.
Yeah.
You can see high esophagus arch, as well as the tissue plane is also very flimsy.
Yeah. Go up, please. Go up. We can see the arch of aorta is bending here, right? So we'll again now try to dissect away from the arch of aorta. This is the subclavian arch, brachiocephalic. Go in. So actually this should be the region of the esophagus arch, which we are not seeing here. It's quite high in this case. So I will move upward. This is the trachea basically. The trachea should be, the esophagus arch should be at this level. It looks like the esophagus arch is quite freely mobile without being covered. This is covered only from this side with the leaf of the pleura, but it has to be covered thoroughly through and through. So you can make a leak here. Go up. ए घटाइदिनु हजुर त्यो घटाइदिनु त go in. Straight.
So we have another question by Dr. Robin.
Yeah.
Precautions taken to avoid tracheal injury.
So we should be exactly in the plane. So you can see here the membranous part of the trachea is this one, right? So intermittently garo na. So we have to be very cautious about the injury to the trachea, right? That's very right question. We can see a plane here. This is the esophagus. This is the membranous part of the trachea. We should work exactly in this loose airway tissue. If you deviate a little bit towards the esophagus, you will rupture the esophagus. If you move towards the trachea, you will make a hole in the trachea. So we should be very clear. So we can see the trachea, aorta here also. So I'm going very gradually, right? No, okay,
Okay.
Vidra.
6 liters per minute.
So you see esophagus arch is almost at the level of the apex. This is the subclavian artery. So it's lying quite high. Here, go in here, please. Okay. So now I'm at this point also we don't need to make a hole in the aorta. So there is a small branch of the vessel. Go in, go in. Harmonic or bipolar? Harmonic? Harmonic. So for these vessels we have the luxury of using the harmonic. You nuclear. खै त go in. Okay, give me the hook. Hook. Okay. Go in. So Dr. Robin, is there some more questions regarding the steps? Today I am going very slowly because this is the live case. I don't want any mishaps to happen.
So there is another question.
Yeah.
Please explain again regarding dissection around the azygos and its preservation. Is it routinely preserved?
Okay, very nice question indeed. So just in a moment I will come to the azygos arch again. So I will just bust this vessel. This vessel is coming directly from the aorta, that is the esophageal branch. So I need to take it out. Okay. This one also, you can see there was a question, where is the left vagus nerve? So at this location we can see the direct esophageal branch. So at this location also comes the left vagus nerve from the left side, because this is the right side of the chest cavity, that's the left side of the chest cavity. At this region location generally comes the left vagus nerve. So the question was regarding, just a moment, I will seal it again. Go in. So there was question regarding the preservation of the azygos arch. So actually, in fact, we can see here, if you see clearly, this is the trachea is this one, right? This one. Trachea is going up to here. It divides in the right main bronchus, followed by hook, please. This is the left main bronchus. This is the carina, right? So the azygos arch, this corresponds to the D4 vertebra. So at this location should be the azygos vein. This azygos vein should come like this and go into the superior vena cava at this location. But what has happened, it has moved upwards. Maybe you can show here, this will be the normal location. So you can see this will be about 2 centimeter, then another 2 centimeters. It's almost 4 centimeter higher than the normal location. So this is draining into the superior vena cava here. You can see the superior vena cava. The location should be here. This one thing, this is the anomaly that we detected today. Regarding the dissection around the azygos vein, I just in a normal person, you can see this, the pleura was present here only. The pleura should have been present here also. So we need to cut here, and then we mobilize the azygos vein. But in this particular case, due to the anomaly, it has been covered only from this side. Only anterior surface and the anterior superior surface of the azygos arch is being covered, right? We don't see any coverage from the behind. So if the azygos vein is not invaded by the tumor, or we expect the positive, we do not expect any positive margin, I routinely do not ligate the azygos vein. If you need to ligate it, we can insert a suture or ligature. Simply number one, silk suture can be enough, or you can use the hemlock clip, or you can use the stapler, whatever you want. Routine practice in my scenario is not to ligate it unless it is not invaded, or unless there are no lymph node in vicinity with the azygos vein. Go ahead. Is everything all right, Dr. Rasmi? So Rasmi and Dr. Yogesh, they are doing a nice job here, making us comfortable with her anesthesia. So I would like to say that we have done only single ligament tube. We do not do the double ligament tube in the case of esophagus. We do not collapse with the lung because we are using the CO2 pneumothorax. The region that are infested, when you keep the double ligament tube, what happens? It makes your job more complicated. So you can see this is also very anomaly. Here you can see the aortic arch. This should be the brachiocephalic trunk, right? So this should be brachiocephalic because the first branch from the aorta, aortic arch. So this should not be visualized like this. But in the, sorry, I'm very sorry, this will be the brachiocephalic trunk should be the right side, right? This is the left side. So this will be the left subclavian artery or left common cardiac, because the arch of aorta goes like here, the subclavian artery right is here. Go in please. Show me the up at the apex. Oh no, this is the brachiocephalic. Yeah, this is the brachiocephalic because the right subclavian artery, this one. So this we don't see routinely in a case of esophageal cancer surgery. So it is, there is indeed some anomaly. Go in please. So we should be careful also in this location also. Go in please. Go in. Go in, Sagar, please. Yes, Dr. Yogesh, you wanted to make some comment. Dr. Yogesh, can you give the mic to Dr. Yogesh? You wanted to make some comments. Go in. Yeah, can you give the mic to Dr. Yogesh? You wanted to make some comment. Go in.
Hello, good morning everybody.
So do you want to make any comment, Dr. Yogesh?
No, do you have any
Good.
question regarding anesthesia?
Good.
I would like to answer. Me and our team like to answer.
So I've lifted so far the esophagus from the trachea. So in a normal patient, you want to do the supracarinal dissection, you should look for the recurrent laryngeal nerve in this location. So I'm not seeing it since the patient has got the G junction type 1 severe. After the chemotherapy and the CT scan, we don't see any lymph node around this. So I would not try to dissect it. There's some another vessel here. I'm not quite sure what is this. This one. So this patient has indeed some anomaly of the, some anatomical anomalies. Go in, please. Go in, Dr. Sagar. This should be the recurrent laryngeal suction. Suction. So we can see this is the right border of the trachea. This is the left border of the trachea. I have lifted up the esophagus. Go in, Sagar. So this should be, there is a structure, I can visualize this one. This should be the region of the left recurrent laryngeal nerve. Left recurrent laryngeal nerve. So I don't see very properly, but should be this way. Maybe during dissection we can find it out. But in this particular case, I am not planning to do the recurrent laryngeal nerve dissection because first he has responded well to the chemotherapy. In the CT scan, we didn't see any lymph node over the superior mediastinum, so we are not going to dissect it out. Go straight, yeah. But in a case if the tumor is located in the middle esophagus, we will truly perform the superior mediastinal lymph node dissection. Go in, please. So we can see here is the level 7 lymph node, subcarinal lymph node, which we'll take out in a moment. First we make the dissection here around this. Go in. Go in. Go in. Yes, sir. So there was a question regarding the left vagus nerve. So now we can see the left vagus nerve very properly. I will show you in a moment. This one, I cut it. You see this one? This is the left vagus nerve. Dr. Robin, can you see this? There was a question regarding left vagus nerve. So this was the left side of the thoracic cavity from where it traversed. So there is another vessel here. This is the direct esophageal branch, harmonic. No, I don't repair it because there is no necessity of repairing it. And secondly, either to put the chest tube or do not put the chest tube, it depends upon you. So routinely in our practice, I do put the chest tube in the left side also if you open that, because in the next day you can remove it. So because of the pneumothorax, CO2 pneumothorax, if there is the CO2 there detention, so that will reabsorb not in a moment of time. I mean the next day you will not see that pneumothorax. Okay. Go in, please, sir. Suction. Bas piste aate. Bas. Liga sir. Liga sir. Liga sir. Yeah. Suction. So I believe in the practice of doing the extensive lymph node dissection according to the protocol. So if the tumor is in the distal esophagus, there may not be any necessity of performing the supracardial lymph node dissection. If it is adenocarcinoma, if it is a squamous cell carcinoma, yes, we do the superior mediastinal lymph node dissection as well. Total mediastinal lymphadenectomy. Is suction आया है ना? Suction आया है ना? So it depends upon the location and pathology of the tumor. So, yes. Sorry. Go in, please. Yes. Hook. So now we can see very clearly the left side of the lung, the left side of the pleura, and also the left side of the inferior pulmonary vein. So this is the left inferior pulmonary vein, left side. Go in, please. Go in, please. Go in, please. Go in, please. So we can with the lowermost resection in this side is the left cross of the diaphragm. You can see the left cross of the diaphragm. This one is the left cross of the diaphragm. So we have listed the lowermost limit of the dissection here. Go in, please. Yes, this is the hiatus. You can see this one. This is the hiatus, right? Okay, so the lowermost part of the dissection is done in this side. Go in this side, please. Go, please. Go, please. Suction.
So we have a question.
Yeah.
Do you use surgical tape to retract esophagus if
Not
there is a
routine.
problem during dissection?
Yes, sure. We do use if there is there are several lymph nodes or something is disturbing us, then we routinely use the tape, but we do not need to do it. Sometimes only we can just take the tape and retract the esophagus like this. Go in please, go in please. But routinely we do not use it. त्यो हल्ला नगरौँ नि त्यहाँनिर चाहिँ। उता गएन खै अब के गर्नु त्यस्तै हो अब ट्राई त सबै गरिरहेछन् न अब अर्को पालि अझै गर्नु पर्यो। So we have reached the apex. You can see this is the boundary. The thoracic apex is marked by the subclavian artery. So we can see the subclavian. I can open up the pleura a little bit more for you. Go in. Go in. So you can see here, this is the subclavian artery. Right, go in. Go in, please. Go in, please.
के भयो एकचोटि हेरौँ न।
Go in, please. Go in. Go in. Go in. Okay, so we have finished almost the whole esophageal dissection. You can see here. Go in, please, a little bit. Go in, please. Okay, now we'll take out the last moment of lymph node here. Yes. Go in. Go in. So this is the subcarinal group of the lymph node. Go in, please. Go in little bit. So at this point also we should make a precaution not to injure the tracheobronchial tree. Go there. So actually this is also a very nice question because we have several times had the tracheal injury also. So the most common size of tracheal injury I would say is the upper part. I mean the membranous portion of the trachea. So I will show in a moment where do we injure it. And so far the reconstruction is considered when you have the injury, the management is just with the laparoscope. With the thoracoscope you can repair it very easily. No need to open the patient once you have the injury to the trachea. So it depends whether you have recognized it, recognized it intraoperatively or postoperatively. If you have recognized it intraoperatively, definitely you can do it during the same setting. You don't need to open up the patient. But if you have recognized in the postoperative period, then you can try with the again with the minimally invasive surgery. No need to open the. This is the 107 according to the Japanese classification. Or otherwise you can say the subcarinal group of the lymph, because you can see this is the right main bronchus, this is the left main bronchus, this is the trachea, and this is the carina. So this is called the subcarinal lymph node group, which we have taken out. So I am leaving the subcarinal group of lymph nodes here. Suction. So the question was, where do we injure the suction? The question was, where is the commonest site of the injury to the trachea? So I would say we can see the trachea. Go in, please. So this is the floppy part. This very loose floppy part, so we can easily make a hole into the membranous portion of the trachea. So this is the part. Suction ulto राखेको छ फेरि के हैन, यो उल्टो राखेको छ suction ग्यास पर्दैन एउटा, त्यही भएर suction नआएको, suction उल्टो फिट गरेको छ. So we can see this is the part, this is the segment where it is generally we make injury to the trachea. So if this happens, we can just make a suture here with a 40 PDS or 30 PDS, wherever you want. Yes, yes, sir. Pardon?
what are the pointers for the end of the superior dissection?
So the end of the superior dissection, you can see, go up please. So we have reached the apex of the thoracic inlet. So this is the apex of the thoracic inlet because this is the subclavian artery, you can visualize. Go in please. Go in please. So this is the end of the dissection superiorly because we can reach a little bit more in the neck. Go in please. So this is the end of the dissection because we have already reached in the neck. You can see this is the neck, right? Yes, Dr. Manoj, do you want to make some comment? Go in, go in, go in, go in. Go in, hook, hook, hook. There are some other branches, direct branches to the esophagus you can see here. Sorry. Go in, please. Vision is a little bit blurred, Sagar. Maybe the focus is not good. So go in and focus. Go closer and focus it. Yeah. Okay, good. Perfect. So this we have reached in the neck. Going. So this will make the job of the neck surgeon easy because much of the dissection has already been done from this side. Go in, please. Go in. Go in. Go in. Yes, I think that's it. You can see, is it clear, Dr. Sachit or Robin? The question was here, this is the apex is here. We can move a little bit 1 centimeter deeper inside the neck cavity. So I think now we take the clip. If there is no question, I think we have finished with the thoracic part of the esophagectomy. So it's very easy to do with the VATS approach. We don't see any bleeding. Everything is very clear. Everything is under vision. So now at the last, our routine practice is to clip the thoracic duct which is mobilized here. So put the 10 mm port here. Question answer? Nice. So we can see here, so we'll put a 10 mm port here. The 5 mm port will convert one of the 5 mm port for the insertion of the clip and taking out the gauze piece that we have inserted. ग्रास पर्दैन अथवा मेरील्यान्ड दिनु मलाई अनि क्लिप दिनु उताबाट सजिलो हुन्छ क्लिप ल्याउनु yes please is there any question?
Is it always necessary to ligate the thoracic duct?
No, it's not necessary to ligate if you are quite sure that injury has not been done, but in our practice I routinely ligate is in fear of having the post-operative cryothorax. Our routine practice, it's not essential. Cut, clip. Okay, good. So that's it, because the 2 minutes of job, it's done. I think it's better, take out the gauze piece. But if you wish, you can avoid it. So now I'm taking out the gauze piece. So I think Dr. Robin, you can have a cup of tea so that we change the position of the patient. We now put the chest strain inside the chest cavity. And now we'll change the lymph node. Please take out the lymph node. Yeah. And now we'll change the position of the patient. I will drape again. So it will take maybe 10 minutes extra. So you can get and have a cup of tea. Robin, sir. Yeah. Yeah, Dr. Robin. Hi. So we have finished with the thoracic phase. So now you can have a cup of tea so that we change the position of the patient and do the laparoscopic part. Okay, just give us 5 or 10 minutes.
Sure. Thank you for the lovely. Can you just clarify on the two things? One is the proximal extent of dissection because the transmission was shaky at the time. And
okay.
Second, what happens if? How do you tackle a post-operative deeply detected of the thoracic duct?
Post-operative, you mean? So that's why if it doesn't have, we routinely clip the intra ligation of the thoracic duct. If you have not clipped it, or even if you have clipped it, for example, we kept the clip here somewhere. This one is the clip, right? So if have not clipped, or it happened in the post-operative period anyway, the chylothorax is happening, then it depends on the conservative protocol. So generally 2 weeks of protocol have been advised. You would give the TPN and NPO or the fat-free diet, or low channel fat containing diet you can start with. If it doesn't resolve, then you have to take the patient for surgery. So it depends on the output, type of the chylothorax, and if it is there, if waited enough for the conservative treatment and doesn't resolve, then take the patient for the surgery. At that time, I would request you, my recommendation is you to start with the ICG. You do the ICG and you can visualize very well the thoracic duct. And that,
What about mass closure of the tissue between the aorta and the esophagus vein?
so that's true. That's what I was trying to talk about. So if you are not using the ICG, then you can at this location. This is the diaphragm, right? This is the esophagus. This is the aorta. This is the esophagus vein. So at this point, at the lower limit, that just above the diaphragm, you can take a suture and mass ligate it. But what I think is, what I say that the chances of injury at this point of time, at this place, is very rare, because the esophagus is too far away from the aorta. Yeah, but in the yes, Dr. Robin. Could you? Yes, sir, upper. Dr. Robin, I would just one more thing that I would like to clarify. You said the uppermost limit of the dissection. So this is the thoracic apex, because we can visualize the subclavian artery. This is the right subclavian artery. This patient has got 2 anomalies. The first is the high insertion of the esophagus arch, this one. Second is the very low origin of the brachiocephalic trunk, which has gone here and done the right subclavian artery here, and right common carotid artery should be going upward. So this is also not commonly seen, because you can see the arch of aorta, it's very clearly seen, right? This is the aorta. This is the arch of the aorta. The first branch is the brachiocephalic trunk. So we have found 2 anomalies in this patient. So I request you, if no questions, I request you to take the cup of tea. Then we change the position of the patient and we'll back to you possibly in 5-10 minutes of time. Dr. Robin?
Thank you. You've been so clear. There are no questions in the audience.
Oh, thank you very much. Thank you. So just take a cup of tea, enjoy there. You can have discussion. If somebody has the questions here, you can answer here, because there could not be any better person than you in the audience. And you can, Dr. Sangam is here, our next anesthesiologist, very enthusiastic. Can show Dr. Sangam. Yeah. Huh? Light action बंद कर, light बंद, होइन light पर्दैन बंद गर्न, पर्दैन, योगेश, sure, त्यो भाइले भन्यो फेरि के चलायो, फेरि के हो त्यहाँ मिस्टेक हो. यो ग्यासहरु अफ गर्दिन, गस पिस निकाल्यो, ग्यास अफ गरेर त्यहाँ
एउटा मात्र रबिन सरसित बोल्दा बोल्दा यहाँको आवाज हरायो अरे के सर, अनि त्यो
masih pistol lah ya. Wah. Halo. Obat cek. Halo. Kaki di session boleh atau ini lagi. Halo. Halo. Oh, ini For now. Hello. Hello, sir. Am I audible? Hello. Hello. Am I audible on TV? Hello. Hello. Hello.
Hello, hello,
You might got बोले
hello.
माथि उठ्न सुन्नु पर्यो उठ्न सुन्नु
Offer, offer then. Hello. Discord त अफ छैन. हेलो 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 सुन्नु आहा. हेलो 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 हजुर ठिक छ. हेलो 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 हजुर हजुर बोल्नु छैन आवाज आएन टिभीमा आएन.
कसले बोल्नु प्रिन्स तेरो Hello, Prince. Am I clear? Hello. Are you clear, sir? Audio मतलब understand गर्न सक्नुहुन्छ मलाई. Hello. अहिले कस्तो छ? Hello. अनि माइक एकजनालाई दे भिडियो अन गर भिडियोमा चाहिँ जस्ट इमेजिङ गर उता पट्टि हेरे त टिम
स्मल बट
म बोलेको
स्मल बटलाई
अब कति
माइक माइक अन गर्नु त कस्तो भयो माइक अन
आवाज
मैले सुन्नु
अनै छ. हेलो हेलो हेलो
मोबाइल सुन्दाखेरि
म यो बोयाल
अब आउँछ
म बोलेको सुन्दाखेरि थ्रु टिभी सुनेछ सुन यहाँ त प्लास्टिक हेरेर मेरो डिस्कोड खोल ल्यापटपमा है मेरो डिस्कोड खोल ल्यापटपमा मेरो म्याकमा डिस्कोड
अब त्यहाँ त्यहाँ ट्रेन्डमा गएर अनि एड गर don't implement space any कुनै गरेछ म्याक पढेर है अब अब के हुन्छ भने बाट चाहिँ कम्प्युटरबाट सागरकोबाट चाहिँ माइक त्यहाँबाटै छ भिडियो सेसन त्यहाँबाट मैले भन्नु त हेलो म बोलेको म्याकमा सुन्ने म बोलेको म्याकमा सुन्ने छ किन म बोलेको 1% नि सुन्ने छैन म्याकमा
टिभीबाट आवाज आइरहेको यहाँबाट बोल आइरहेको
म्याकको भोल्युमबाट क्लियर छ म्याकमा अब तैँले के गर भन्दा आफ्नो के आरओजीको भोल्युमलाई 0 गराइदे भोल्युमलाई 0 गरा के ल्यापटपको भोल्युमलाई 0 गरा आरओजी भोल्युमलाई 0 गरा के ल्यापटपको आरओजी भोल्युमलाई 0 गरा के ल्यापटपको
बोल्नु न बोल्नु
म्याक म्युट गर म्याकलाई म्युट गर म्याक चाहिँ म्युट गर म्याकलाई म्युट गर ओके अब म बोलेको आइरह म्याकमा क्लियर छ ओके गुडिया यो चाहिँ ल अब मेरो ल्यापटपलाई चाहिँ त्यहाँ नजिकै राख्दै ल भयो सर माथिको समस्या समाधान भयो कुनमा छ यसमा 172 172 16 200 कति होला नि केही माथि सल्भ भयो हेलो अब चाहिँ टिभीमा हाल्दै टिभीमा अब के गर्नु यता म्याकलाई पनि भोल्युम अफ गर तर टिभीको चाहिँ फुल गर आरओजीको फुल गर अथवा म बोलेको पछि ल्याएर सुनाए होइन क्लियर छ म बोलेको क्लियर छ ओके ल अब के गरौँ यहाँबाट खोज्नु यस सरी होइन उताबाट माइकबाट बोल्नु न फोनमा त क्लियरै छ माइकमा
हेलो
त्यो मेरो ल्यापटप हो
यो कन्फरेन्सबाट माइक टेस्ट गर्दैछ आवाज आएको छ कि
ल्यापटपले चाहिँ होइन झन् फास्ट हुन्छ त्यही समस्या यहाँ यदि
कन्फरेन्स माइक टेस्टिङ ओटीमा आवाज आएको छ कि छैन
माथि एउटा 3 लाख हेलो माथि त्यो डिस्कोडमा आवाज आइरहेको छ डिस्कोडमा जाने माइक सेटिङमा जाने अनि इनपुट डिभाइसलाई चाहिँ डिभाइस सेलेक्ट गर्नु
दुईटा माइक मसित छ
अब बोल्नु त
सर एकछिन
माइक
बोल्नु त माइक
होइन ल्याप्रोस्कोपी
ओके क्लियर म बोलेको क्लियर
टेस्टिङ जोडेको छैन
हजुर
टेस्टिङ
ग्रासपर फेरि मेरिल्यान्ड सेरिल्यान्ड ल्यायो होला के ल्यायो होला ग्रासपर कुन ल्यायो फेरि
हेलो
नाइफ दिनु
हेलो त मेरो आवाज आइरहेको छ टिभीबाट आवाज आइरहेको
टेलिस्कोप यताबाट अनि मलाई ऊ यहाँबाट जुत्छ कि यहाँ राख टेलिस्कोप म ह्यान्ड इन्स्ट्रुमेन्ट यहाँ राख्छु यताबाट गर्छु यहाँ चाहिँ यो मलाई हार्मोनियम अनि उसको चाहिँ ट्रली यहाँ राखिदिनु कि इन्स्ट्रुमेन्टको सिस्टर ल्याप्रोस्कोपको इन्स्ट्रुमेन्टको यता कि मलाई लिन सजिलो यता हटाइदिनु अनि यहाँ कि
जस्ट इमेजिङ हैन टप क्यामेरा जस्ट इमेजिङ
स्क्रिन लगाइदिनु अलिक पछाडि लाग्छ थोरै ल पुग्दैन भने ठिक छ पेरो मलाई ग्लोभ्स च्यात्ते समाज मन यहाँनिर यहाँ
टिभी छ नि टिभी
ग्लोभ्स साथको
स्पोर्टमा हाम्रो म देख्नु पर्यो टिभीमा म देख्नु पर्यो म भन्दा नि यता देख्नु पर्यो
महेशलाई भन्नु न अब हामी आउँछौँ लाइनमा महेशलाई
अब अर्को चलेन होइन त्यो म यहाँ म कुदेर आएँ
भयो रेडी हो
साउन्ड ठिक छ
सबै यहाँ के यहाँ यता यता राख्नु नि यसमा के यहाँ राख्नु नि ट्रेन यहाँ त गजाङमा कि यहाँनिर हाल्ने दिनुहोस् एउटा
साउन्ड आएछ
यसलाई उता राख्नु त सिस्टर कस्तो गजाङमा ल्याइन्छ यो तलबाट
हेलो के रे
यसरी राख्दा पनि भइहाल्यो यसरी राख्दा भइहाल्यो हेलो
सन्दीप ल्यापटपको साउन्ड आएछ किन रोक्यो कहाँनिर गयो
ए उ गर वाइट गर्ने इट्स ओके
डाक्टर सन्दीप साउन्ड आएछ
हेलो
बोल्नु न उताबाट
सुनिएछ त्यहाँ सुनिएछ
अनम्युट गर त अनम्युट
यहाँ सुनिएछ
जेरेस
प्लिज
हेलो हेलो हेलो
आवाज
आएछ आछ
हाम्रो साउन्ड आएछ है
आछ यताबाट आछ
गस पिस
उताबाट पनि आछ
गस पिस
हजुर आजलाई यो
syringe.
Yes, ready गरौँ है खाना
Syringe.
आजलाई म मस बोलेको
Light shorts on.
आजलाई म मस बोलेको स्क्रिन अगाडि जानु देखि
के हो
यता
फ्लो बढाउनु पर्यो
आज खाएर The gas on.
ग्यास अन गर 15 मा राख ग्यास फुल पोजिसन
मर्निङ एकदम नेट स्लो भयो आज हाम्रो
हाई
लाइभ
फ्लो।
चलिरहेछ 8:50 पुरा
ल जे छ छोड
गराइदिनु एकदम एउटा केस सर बिना सर
गइरहेछ ग्यास गएछ आशिष मलाई माइक लगाइदिने हो आशिष माइक लगाइदिने हो अडिबल छ त्यहाँको यो होल्ड गर्छु यहाँ होल्ड सो नाउ वी आर डुइङ Dr. Robin Dr. Ashish Dr. Robin are you online? So we are starting with the laparoscopic phase.
हेलो वेलकम बैक
Yeah, Dr. Robin, so we are starting with the laparoscopic phase now. Can you hear me?
Can you show us the brief port procedure first?
Yes, so we have started with the laparoscopic phase. So you can see we have started the varus needle here. Yeah, so now we are making the optical port, the 15 mm list. So now we have raised the pressure to the optimal setting, that is 50 millimeter of the mercury.
Can you hear it at back?
Lap. Gas off गर्नु त्यहाँ रिबन गस So now again we are cleaning the port. फोर्स और काला इंजुरी हो गया लिम्फ नोड हो तेरे तो मतलब कोरोना इंजुरी हो गई समझ रहन रहा So now we visualize the laparoscopic vision. So here look at inspect the lever, there is nothing, the colon is dilated.
We can't see the
Pardon?
transmission. We can't see the transmission. We can hear you, but we can't. Yeah, we can see you now.
Pardon? You? Now is it okay? So now I'm putting the next four. Yeah.
Yeah.
5 mm knife. So now inserting the another 5 mm port here. We'll do in the V fashion. This way. Yeah. 5 mm को दुईटा दिनु
Video so that the put side is see.
5 mm गस पिस दिनु नि छैन छोड यो बन्द गरेर दिनु अर्को 5 mm अर्को दुईटा 5 mm छ यो नाइफ दिनु त नाइफ नाइफ उता देखो त दुईटा 5 mm गयो अर्को 5 mm So we would like to show our port position. Can you show our Sagar port position? So clean the camera, please. Ligasur. Grasper. Laparoscope.
Yeah.
This one. So you can see here. This is the 10 mm optical port co-closure. This is the head end of the patient. This one. The neck is here where we have painted the neck. Right. This is the abdomen.
Yeah.
This is the foot area in the patient. So 10 mm of supraumbilical. The umbilicus is here. So 10 mm port has been inserted for the telescope, and we have kept in the V fashion. This one, like this V fashion, 2 5 mm port. One this one, another this one. The second, the left side, and the fourth also. Typically in the V fashion, supraumbilical ports have been inserted. So give me the 2 graspers, please. Another. Yellow. मलाई अर्को ग्रास्प गरिदिनुहोस्. सो जस्ट सरी यो यति हो. मलाई अर्को ग्रास्प गरिदिनु. सो यो गिभ मी द गज पिस, ल्याब गज सिस्टर, ल्याब गज. यसबाट ल्याब गज निकाल, ल्याब गज राख्छु. तिमीले यो लियो भने चाहिँ ऱ्याचेट गरेर यही हातमा लियो. त यो हात जिम्मा दिए पनि हुन्छ, त्यो मलाई दिन्छ. लिभर रिट्र्याक्ट गरेर हो प्रिन्ट. एक हातले स्टमकमा तिमीलाई भन्छु, यो हातले स्टमक माथि लिफ्ट गर्ने, यो हातले ओमेन्टम तर लिने. ठिक छ, म बिचमा ग्यास्ट्रोकोलिक लिगामेन्टमा जान्छु. इसको स्टाइलेट देना तो ये छिड़ाना स्टाइलेट. वाह. So okay, show. Sorry. Go here. Don't rotate the camera, please. Okay. So. Okay. This one. Okay. Take this one. Another ले. ये ले. ठीक है. Very jumbo. Okay. ल अरे मेरो च्याप्यो मनोज. Okay. Up. देखो यहाँ. So now we can visualize. This should be the gastroeploic artery. So now I am lifting this up. This one. Yeah. So I will open up the gastrocolic ligament here. देखिए. तलको ओमेन्टम थाहा नमन. Okay. Yeah. So I'm trying to open the gastrocolic ligament here. Go in, please. Shoot it.
Yeah, thank you.
Cool, yeah. Sure. Okay. Yeah, okay. So now I have opened the gastrocolic ligament, you can see here, right? So this I put my grasper here, going. So you can see the colon is down, the gastroeploic vessel should be somewhere here. This one is the gastroeploic vessel. So I'm moving here.
Apart from the gastric curvature, do you stay while doing this dissection?
Pardon?
Apart from the gastric curvature, do you stay?
I didn't. From the gastroeploic vessel, you mean?
Yeah.
So I try to remain at least 2 to 3 centimeter away from the gastroeploic arch. So you can very well see the gastroeploic arch. It's here. This one is the gastroeploic artery. So I try to remain quite a bit far from here, not to injure the colon at the same time. देखेन साह्रै यहाँ भित्र भित्र गोइन फोकस इन फोकस भएको छैन ओके प्लेन दुईटा फर्म भएको छ यो प्लेन ठिक छ भित्र गएको होइन मनोजको के भएको थियो यो यसरी तान यो मोमेन्टम नतान्नु छोड्दै छ स्टोमक छ ल अलि भित्र गयो गयो minimum or maximum. I think it has not come yet, perhaps. Okay. Okay, that's good.
Ligature.
This is the Gen 11. This is the Gen 11 harmonic from Johnson and Johnson. They are provided with the instrument today for the conference.
Yeah. Otherwise, your preference is the harmonic or the ligature?
This is the harmonic. My preference, I don't know, in our setup, none of them are available. Just right now, we have some of the pieces of the ligature, so we have been using the ligature. Only limited piece. So I think in a month of time, that will be gone. Then we'll depend upon the bipolar only.
Okay.
It's the government institution. Sometimes the instruments are available. Many of the times not. यो मनोजको एक तानेको यो जुन छ नि यो तिम्रो माथिको कुन हो स्टोमकले यहाँसम्म छ समाज छोड 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 होइन यता यो तलको खै त हुन्छ पर्दैन पर्दैन ए मास ए हुन्छ हुन्छ उठाइदिनु हटाइदिनु ओके गुड भित्र भित्र यो तिम्रो कुन यसरी तान्नु नि छोड त यतातिर तान्नु हो ओके ओके गुड यो कहाँ यो इन्स्ट्रुमेन्टले नजिक यो छोड त यो छोड यो कुन हो हेतन कोलनलाई तल लगा यो कुन यो यो कुन इन्स्ट्रुमेन्ट हो यो छोड्दै यो मिलेन कि यो okay, यसरी. So we can see that we have opened the gastrocolic ligament. So now we are moving towards the spleen. यो कुन हो यो स्टोमक तान्नु त स्टोमक कुन हो ओके ल ल ओके ठिक छ ल ओके. So now we are again moving in the gastrocolic ligament. Now we can see very clearly. Go in. The traction and counter traction is very important in this set. Go in. Go in. Camera. Okay. Go in.
Can somebody please elevate the bed?
Elevate the bed, please. Yes, we forgot to elevate the bed. This is a minor step. We have to do it in order to avoid the traction and provide the counter traction as well. No. Bed the down गर्ने head and elevate गर्ने के
That's why you
grasp गरियो तलको हो स्टोमकलाई माथि. Okay, good. Head and elbow. Baba. So these are the short gastric vessel we can visualize now. Traction. So these are the short gastric vessels. So this is the gastrosplenic ligament. So we will seal it. We should be just in between the short gastrosplenic ligament, not to damage the spleen. Sorry.
What do you use to routinely retract the liver during this procedure?
Pardon? We can retract it, but generally I don't do it. Clean the camera. मतिर बेड अलि टिल्ट गरिदिनु मतिर So I do not use generally the liver retractor. Hemlock clip चाहिन्छ है hemlock clip. Sorry. Liver तिमी तान्नु छ यो तिम्रो यो सागर ल यता न सागर ल ओके. Go in please. Okay. Sure. Okay, I need my grasper also to reposition. Okay. So I'm still in the short gastric, in the gastrosplenic ligament. Go in. This is again another short gastric vessel. Generally, there are 3 to 5 short gastric vessels. So I think so far we have ligated the 2 of them. So below we can see the pancreas. Liver, okay, good. Oh, good, very good. Sorry, okay. So go in, please. So this is another short gastric vessel. This is the posterior gastric vessel. Oh, sorry. Go in, please. Go in, please. The stomach is very close to the spleen. So this doesn't matter because this part of the stomach can be discarded at a later point of time. Binami sir, sir?
You have got thunderbit also.
No, where? No, right now we don't have thunder. We have the machine of the thunderbit, but right now we don't have the hand instruments. You turn. The stomach is very close to the spleen. Go in, please, little bit. It's the stomach, right? Yes, sure, that's good. Thank you. So this part of the stomach is anyway going to we need to discard it, so it doesn't matter much. Okay, good, thank you. Yeah, this is the left gastric. We have to first clean the left cross of the diaphragm. So we can see the left cross of the diaphragm. Dr. Robin, this one? This one is the left cross of the diaphragm. Yeah. At this place, quite often we can see the left inferior phrenic artery. So you can visualize the diaphragm. This is the inferior phrenic artery. So now we have opened the chest cavity. Now you can see here. So that part we had dissected away, dissected from the during the VATS phase of the procedure. Good. Thank you, sir. It's excellent. So now go down. This place. So wait a moment. This. Yeah, yes, sure. That's good. Sorry. Yeah, Manus, yes, you open it. Okay, lift this one like this. Okay, go. No, this. Catch the stomach. Okay, lift up. Okay. 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 So we can see now the left gastric artery is here. This one. This is the pancreas. So I will open. Go in. So I will go over the upper border of the pancreas. The Gospis, where is the
What's
Gospis?
the extent of lymphadenectomy here?
Oh, sorry. Where is the Gospis? Oh, this one. Pardon? What did you say?
Yeah, what's the extent of lymphadenectomy here?
Pardon? What was the question, please?
For this CH1 types, what is the extent of lymphadenectomy here?
For CH1 type,
In the abdomen.
what is the extent of lymphadenectomy in the abdomen?
So we'll do according to the Japanese protocol, D2 type lymph node dissection according to the Japanese protocol for the esophageal. Clean the camera. So for that we do the infracarinal lymph node dissection. That is the routine two-field lymphadenectomy. In that case, we dissect out the lymph nodes which remain inferior to the carina. It means the subcarinal lymph node of group, right main bronchial lymph node of group, left main bronchial lymph node group, 108 that is the middle paraesophageal, 110 that is the lower paraesophageal lymph node, and lymph nodes along the aorta and IVC. And that was in the chest cavity. In the abdominal cavity, for the D2 dissection, go in please. For the D2 dissection of the abdominal cavity, we have to take out level 7 lymph node, level 1 and 2 lymph node, level 11 lymph nodes, 8 is optional, but we need to take out the level 8 lymph nodes, and that's it in the abdominal cavity. For the type 1 severe, go in please. So now I'm going above the superior border of the pancreas. You can see here. Go in please. Go in please. Go in please.
Any questions from the audience?
Pardon? Okay, so we can see the crus of the diaphragm. So this should be the celiac trunk lymph node. Okay, sorry. Okay. So now I'm again mobilizing the lymph nodes here. यो तलको कसैको फ्री छ दुईटैको बिजी छ इंगेज छ ओके ठीक छ No. Can you clean the camera, or sir? I think the camera is okay, or focus is properly. Oh, okay, that's better. Oh. So I'm holding the gastropancreatic ligament where it moves the left gastric vessels. So this is the gastropancreatic ligament. So between the two folds of the omentum runs the left gastric vessels. Go in please. So for a while we can go from upside or side. Can you release this stomach? Release the stomach please, both of you. Okay. So we go for lift the liver from here. Lift the liver. Manoj. Here, can you keep the liver here? You grasp it. Manoj, okay. Okay, and Sagar, can you retreat this? Okay. So now I'm going to the gastrohepatic ligament. You can see the caudate lobe of the liver. So this is the gastrohepatic ligament. So we are cleaning it till we reach the right cross of the diaphragm. Am I audible properly, Dr. Robin?
Yeah, we see. We can hear you clearly now.
Pardon?
What about the level 12 lymph nodes? Do we have to go for level 12 lymph node as well?
Level 12? You mean level 12? So in a context of severe type 2 lymph node dissection, we can see the small. It's okay. We can see this the left gastric, left hepatic artery, small branch. If it would have, it would have been bigger than we. If it would have been bigger, we had to preserve it. So regarding the level 12 lymph node, in a context of severe type 1, which the patient is having, we don't need to clear. This doesn't come into the D2 dissection for the esophageal cancer. But for severe type 2, yes, you can do it, but not for the severe type 1. This is not recommended. But if you can visualize that, then you can go in the extensive lymph node dissection. But that has not been proven by the literature or by the evidence. So now we have come to the right cross of the diaphragm. This is the right cross of the diaphragm. Go in, please. So here lies the level 1 lymph node, if any. Yeah, this is the phrenoesophageal ligament, which I am cutting. So Sanjeev, उता काउन्टरमा भन्न लगाइदिनुपर्छ रञ्जनलाई. So I don't know whether we can go for the OPD or not. भन्न लगाइदिन्छ हैन. यो भ्याउन सक्छ सक्दैन स्योर छैन भनेर के. अलि yes, you can retract this one. Oh, so okay. So this bit of the tissue which is holding in between the left cross of the diaphragm. So we have reached the hiatus. You can see it, Dr. Robin. It's very clearly see.
Yeah.
This much we have dissected from the. So if you need to cut you had the question regarding how far we move away from the cross of the diaphragm or the cuff of the diaphragm. So in this case, if there is the invasion, definitely you can dissect or take out the cuff of diaphragm. That is not a big matter. Only one thing that we should remember in this patient particularly, we have the prominent inferior phrenic artery. You can see this one. So that might need to be addressed before taking the cup of the diaphragm. But in this case, we don't require. Sorry. Okay. So, okay, good. Go ahead. Yes, so we can see here the hiatus, right? It's very clear. This is the left cross of the diaphragm, this is the right cross of the diaphragm, that is making the U, right? Yes, so that's correct. Is it clear, Dr. Robin? You can see here both cross of the diaphragm fusing here. This is the left cross, this is the right cross, right? Okay.
Yeah.
Okay. Yes, sure. You can catch the. Yeah, that's true. That's good. So, do you have any other preference, Dr. Robin? Your team may be doing in a different way. This is the way that
I would have
how we do
liked
it.
the left gastric artery earlier.
Pardon? Kire? Kya Assis?
Sorry, we would have probably dilated the left gastric artery a little earlier before that arterial dissection was complete. That would have made the access easier there.
I didn't hear you properly. Sandeep, what was the question? What was the comment from Dr. Robin?
Would it have been easier to ligate the left gastric artery earlier?
I don't do it regularly. Once during the dissection, yes, if comes, then we dissect like it. Go ahead. But routinely, earlier ligation, I'm not used to do it. You mean during the surgery or the preconditioning? What you are talking about?
During the surgery, before you identify both the crush from the abdominal side, if you have ligated the left gastric artery, then maybe the retraction will be easier.
Yeah, that is a good idea, I think. I agree with you. That's how I'm used to do it. Go in. I don't know. I'm not used to that. I cannot answer it properly, but I think that may not be very easy because unless you do not open the gastrocolic, this one, unless you do not open the gastrocolic ligament, you do not visualize, you do not open the. I mean, you are trying to say that you first open the gastrohepatic ligament and then go to the left hepatic artery. That can be done. That's true. You are right. That can be done also. I agree that if you have dissected that one in the beginning, maybe it would help you. So thank you for your
They are
suggestion.
doing,
By the way,
they are doing monthly.
we can try in next patient. This is the artery, right? Hepatic artery? No. Hepatic artery. This one.
Celiac trunk.
This node or
Gastric.
I think this is the hepatic artery. Change the position. Yes, यो पोजिसनलाई उता इट्स ओके उसमा मिडलमा पारिदिनु त बिरामीले यो मतिर टिल्ट छ कि सेन्टरमा पारिदिनु नो दिस ओके नट this node or this the artery. This splenic, this is the common hepatic artery, right? Okay. So you can see this is the common hepatic artery. This is the splenic artery is going here, and this is the left gastric artery, which I am holding with the forceps, right? So this left hepatic vein, this one, and the artery I can show in a moment. Yeah, we can take the vein by harmonic. That's true. Sagar is recommending to take the vein, left gastric vein by the harmonic. So we are going to take the left gastric vein. This is the left gastric vein. So, yeah, in the slow cooking mode. He has given a very good tip. So now we are going to take the left gastric vein in the slow cooking mode of a very fancy instrument. Is the Gen 11. So this is the, we can see this is the left hepatic vein. Sorry, left gastric vein, coronary vein. So we can take with the harmonic. This one, no issue. Oh, sorry. So left gastric vein, coronary vein is gone. So we'll take out all the lymph node from here. So if you want to do precise dissection, I think the hook is the better option. So hook denu takti like clean garunu, give me the hook. Hook ko pedal denu sir. Hook ko pedal denu. Hook ko pedal. Pedal ke hook ko.
The audience is silent. They are mesmerized by the surgery.
Yes, sir.
Our whole team, thank you very much, Dr. Robin, for your nice comments. You people also do a wonderful job. This is the only the chance that we have got this time. Sorry. Okay, it's good. Umesh ko phone उठाइदियो न हाम्रो उमेश शर्मा को phone गरेर भन्दैन. So these are the small pieces of the lymphatic fibers. So I believe that when you see that once this lymphatic clearance has been done, the left gastric artery is really very small in caliber. Generally, I have seen quite a few of surgeons who like it en bloc with the lymphatic. It looks like it's very big, but actually when you clean this all lymphatic fibers, so you will find this is only the left gastric artery. So this all are the lymphatic vessels.
Have you ever had problem with just using energy source to divide the left gastric vein?
Left gastric vein, yes, quite often. We can divide the left gastric vein with the inner resource, no problem. Artery also, this much of the artery you can divide with the energy source, but I'm not used to dividing with only with the energy source. So I think this is okay. This is, we have mobilized all of them very good. So we have inserted the gauze piece, so we can put a clip or you can like it and open it, right? One time. You can take it this one. I can like it. It's okay. Just take it. Yeah, take it. Okay. Take this one. Okay. 20 को try दिनुस् त sister. 20 tie र silk. Try के 2010 जैसा त नि के भएर. धेरै राम्रो हुन्छ पढ्न. So is the vision clear there, Dr. Robin?
Yeah, it's beautiful. Please continue.
Yeah, this we have got the 1588 setup of the striker that we purchased about 15 years ago.
8 years ago.
Here के भयो यार ग्यास हेर्नु त ग्यास ग्यास हेर्नु न पहिला
15 years ago हैन त
ग्यास हेर न ग्यास छैन कि यो कसले टाइट गर्छ नि यो gas is not coming. Okay, nice. So in this particular patient we can use this thread only. Sorry, cord tip छैन sir. Needle holder के needle holder. Your liver यो भित्र जाऊ त क्यामेरा yeah, we have to make the 10 mm port, so we don't want to put the भित्र जाऊ त just only if we put the hemlock clip we have to make the 10 mm port. So we didn't want to make several ports here because we have to make a mini laparotomy at the end to take out the specimen, so which we want just to avoid it. Who's final sir? Going. यो ग्रास पर च्याप्दैन फेरि बस कार्ड वाला दिन में एक ही एंगल जा भीतर जा यो च्याप्न पनि च्याप्दैन निडलले ओके ये सबै ग्रासपरहरुले सबै फुत्क्यासक्यो हार्मोनिक सिजर गरे सिजर अब ओके सिजर गरे सिजर harmonic. So now we can divide with the harmonic. So this is, I think this is the safer way of dividing the, though we can use the energy source also for this purpose. Okay. So now we come this side. This side. Manus को ये stomach चांदे उसमें समातेर and then the momentum okay mother okay uta tirtan uta okay lega sho यो कुन हो तिम्रो यो यो ओके लिगासर यो हार्मोनी यसलाई समाते एकजना नै त अलि पछाडि अनि अलि यो ठाउँ ओके यो हाम्रो ग्यास्ट्रिक कोलिक आर देख्नु पर्यो त्यो ओके ओके गुड सो ओके ओके
Dr. Vinay, how to identify the left gastroesophageal?
Pardon? आशिष के
Yes, sir.
सोध्नु भएको छ डक्टर रोबिनले आशिष
Yes, sir.
के सोध्नु भएको छ डक्टर रोबिनले देयर वाज अ क्वेशन फ्रम or comment from the Dr. Robin.
Yeah, here, how do you identify the left gastroesophageal and
Pardon? Huh? के भन्नुभएको ए आशिष सोध्नु I will show you in a moment because I had seen it before because that is protected by the grasper. So, I will show you. Okay, I will show you in a moment. राखौँ न के छैन यता जाऊ त यता ओके ओके गुड भित्र जाऊ So at this place we have to be careful because we are coming closer to the gastroeploic, right gastroeploic artery. So we should be careful at this place. Okay. I think we are visualizing the middle colic artery. This will be the middle colic artery. Yeah, let's take it. Yeah. This. So we don't want any tension in the anastomosis, so we are mobilizing this part also. So I will show you in a moment right gastroeploic artery. It's okay. Okay, so we can see at the base, we can visualize just here. This one you can see here. This one is the right gastroeploic artery. This one. Can you see, Dr. Robin, here? Vein and artery both are seen here. Take it, this one. Yeah. Is it clear, Dr. Robin? Could I show the right gastroeploic vessels? This place, sorry. Okay, go here. This, yeah. Sorry. Go to the camera. Yeah, just gently this one. This much.
How do you remove the excised subclavian?
Through the port. We did it through that port. I think. Pardon? We excise the subcarinal lymph node. We removed it through the port. We inserted the 10 mm port, then we removed it. That was not a big deal. We did not make any incision over the chest cavity, only except the port. Okay, this time that's yeah, this is enough. Yeah, this way. So, Dr. Robin, we have to show this one is the right gastrophilic vein and artery. It's very clearly seen. So we protect this. Now take this one. This the adhesion. We take it. Yeah. Okay. Okay. This is good. Yes, so there is a little bit of adhesion here at the hepatic artery, hepatic hilum. Take it. Gas kholo is it? Yes. Let's clean the camera. So far, I think we have done a good job. Assis, can you scrub in and make the incision over the neck? So we'll now simultaneously start with the neck section. So we'll start doing the neck incision. Or Assis, I don't know. Oh, clean the camera again. Clean the camera again. Are there any questions, Dr. Robin? Or any comments? Do you do something differently at your setup? No, I will make a mini laparotomy in this patient and remove the stomach. Remove the specimen, I would say. Yeah, yeah, done. Go in. There was some question I cannot hear clearly. Go in, camera. Go in, this place. Camera, go in, camera. I cannot hear you. Somebody can you listen to the question? Sandeep, what Robin sir is saying? Can you repeat the question, Dr. Robin? Yes. Pardon? Yeah, so we can so we can see this is the right gastric artery, this one. Yeah, this one is the right gastric liver. So we can see this is the right, Dr. Robin, can you see this is the right gastric artery here? This one? Yeah, this is the crow's foot here, the sagar is showing. So I would like to divide the right gastric artery somewhere here, not at the beginning. So I will take it here, take it down. Okay. So I would like to divide the right gastric artery somewhere here at this place, not in the beginning. So that there will be some blood supply from the right gastric artery as well. This was the place? Yeah, okay, go in. Where is Sita? Yeah, the camera. Okay, yeah.
Question is, do we usually do pyrodermatomy?
No, I never do the pyrodermatomy. I never do the private. Yeah, we do the digitoclysis, finger digitoclysis. Lift it. Okay. So now the right gastric vessels is clearly seen. I think that's it. So we can make the straplet here. So we don't have the endo GIA for this patient. So anyway, we are going to open the patient, make the mini laparotomy, and then suture it and remove the specimen. Dr. Ashish, are you ready with the next section? Yes. Yes, please. त सागर यो कोखराइसन गर्नुपर्छ यहाँ त्यही त यो त देखिएन यसलाई समाचार Can you repeat the question, Dr. Robin? In about 700 cases, I had 3 occasions when I needed to do the pyloromyotomy in the post-operative period at 3 months or 6 months of time because of the So only 3 cases so far that in post-operative period, after sometimes 3 months, 6 months of the time, I needed to do the pyloromyotomy because of the delayed gastric emptying. Otherwise, I didn't find any complication of delayed gastric emptying so far requiring the surgical intervention because of simply we did not do the pyloromyotomy. So I do not recommend because at the same time you can have the gastric reflux, biliary reflux. Okay. No. मेरे gallbladder ले समाज दिया okay Mr. Going to it's nothing. हैन अर्को कटरी लिए भइहाल्यो नि यता आउँछ सागर So I'm changing my position. I will go in the middle side of the patient. So I'm standing basically in the right side of the patient, and the camera port was in the middle section. I mean, in between the legs. Yeah, yes, Samata. मलाई ग्रास पर लिगा सर त्यही हार्मोनी एउटा उता दिनु ग्रास यो मलाई केही गलबाट लिफ्ट गरौँ केही हुन्न you can go ahead. So Dr. Ashish is not making the meantime, he is making the neck incision for the neck mobilization because in a short period of time we will be finishing with the laparoscopic part. Nothing. So there are some adhesions in with the gallbladder of the omentum with the gallbladder. So we are trying to release it so that there will not be any tension in the anastomosis, so that we can easily pull the stomach up in the side of the neck. I think this patient has responded very well to the chemotherapy, right? What do you think, Dr. Sagar?
Exactly,
Dr. Manoj?
Yes, sir.
I think it's very good response. We do not see quite often this kind of the response to the chemotherapy. So I think float for regime is it's out of the discussion. I mean, out of the surgical practice, I would say the float for regime should be recommended for adenocarcinoma of the GE junction and the esophagus. Going. Show me this and then Oliver. होइन उनीहरू चाहिँ सक्यो भने ठिक छ आशिष कि को छ सन्दीप हो त्यहाँ अनि if they want to go for the CME section, CAV session, that's also all right. What do you think, Dr. Robin? Dr. Robin, would you like to stay with us for some more time? I think in 1 hour of time we'll be finishing the surgery. Pardon? Get it?
We'd like to see the anastomosis.
Okay, sorry. Okay, good. Then you can stay with us. So our resident, third year resident, Dr. Ashish Kharel, he's in the neck. And Dr. Manoj will be helping him in a short period of time. This is the colon, duodenum, right? Let's check the gallbladder. देखाइदियो मनोज gallbladder देखाइदियो. Okay, good. So now we are trying to do the cockerization so that duodenum can easily reach the diaphragmatic hiatus. So in that way, we can gain about 2 centimeter, 2 to 3 centimeter of the extra length. So that's what we are trying so far. Yeah, so this is the duodenum. We can see this is the IBC is not. So this is the IBC. We can see this the bluish structure is the IBC. Yeah. Oh, okay. Go in camera, It's okay, nothing. duodenum में मनो से कहते जो होता है इसको मनो इंस्ट्रूमेंट देखिए मनो. ओके बस. Go in. Go in camera. So we can see the IBC here, right? This one. So I think this much will be enough. This could be enough. I think that should be enough, right? Sure. So now I will show you the structure. Suction denu. Can you lift the lever? Samadha Manus. Samadha. Sagar, you also lift the lever. Suction denu. What is holding? This is holding. We have to take it out, right? Here. This is something holding, right? Is there something, Sagar? This one? No, this is the vessel. This vessel, right? So I think we'll leave it. So you see the caudal lobe of the liver. So this cross has been camera. So the cross has been well mobilized. Take out this one. So this is the tumor. This part is the tumor segment, and starting from above. So these are the two cross of the diaphragm. By camera. So the stomach has been well mobilized. So we have preserved the right gastrophilic vessel. This is the right gastrophilic vessel, making the arc here. So this is pulsating very well. So it's going to us. You can see the pulsation over here also. So now you grasp it out. So you can see the stomach towards the fundus. It's well mobilized, right? This is the pancreas. There's no much bleeding. So the guspis is here. We shall put the guspis in the vision so that we can take it out. So I think there's hardly maybe 50 ml of bleeding during the whole part of the surgery. Grasper. So guspis no guspis समातेर राख्ने म ल्याइदिन्छु guspis क्यामेरा ग्यास तफ म ल्याइदिन्छु come on camera. So take your grasper. You can take with this grasper, this one. You okay. Then यहाँ राख्दिनु यतिकै यहाँ छोड यतिकै राख्दिन्छ ग्रास्पर सही ठिक छ हो लक लगाइदिनु लक लगाएको छ नि लक लगाएको छ ओके सो नाउ Robin यता आउँदा so now you can see the port here, right? So we shall make a mini laparotomy here somewhere and take out the specimen. Now Assis is making the neck incision. You can see here. सफा गर्नु त guspis. So it is here. He is making the neck incision. Somebody मनोज देखाउँदै गर्दा क्यामेरा. So मिल यो त छोडिदिनुहोस् हैन. So this is the next side. मलाई ल्याप्रोटोमी को हुँदैन. यो के रे यो धर्म यसलाई जोइन गराइदिउ त उता निस्कता सागर त उतै जाउँदा सागर अलिकति क्लोजर जाउँ माथि ठिक छ सो नाइफ दिनु नाइफ ग्यास अफ गरिदिनु ग्यास अफ गरिदिनु ग्यास अफ गरिदिनु यो जोड दिनु नि यो नाइफ दिनु एउटा लाइट यता देखाइदिनुस् एउटा लाइट यता देखाइदिनुस् So he is dissecting the anterior, he has made the incision of the left side of the neck and he is making the incision anterior to the sternocleidomastoid muscle. Can you comment on the structure? No. No. Guspis. Cautery. Guspis. Guspis. Bed चाहिँ सीधा गराइदिनु त Cautery, मेरो cautery, cautery, cautery के मेरो. So meanwhile they are in the neck. I am making mini laparotomy here in the abdomen. Take out the esophagus, hook the esophagus, hook the esophagus. उतै देखाइदिनुहोस् रिट्र्याक्टर दिनु सिस्टर तपाईँ उता जानुहोस् त उता जानु त तपाईँ ऊ छ नि के अरे यसरी गर्छु सक्सनले यसरी
finger like this.
हुक गरेर बाहिर निकाल्छु हुक गरेर बाहिर निकाल्दै काट्नुपर्छ त यताबाट आउनु राइट एङ्गल ट्र्याक्टर राइट एङ्गल ट्र्याक्टर पुरै हुक गरेर माथि ल्याउने है क्यान यु सो द स्ट्रक्चर्स ओभर देयर डक्टर सागर can you give the mic to Dr. Sagar? Sandeep, can you give the mic to the Sagar? Right angle retractor. Can you give the mic to the Sagar? Show the structures over there.
Let's start from the beginning. Okay, so patient head is tilted towards right side and the neck is extended. The skin is extended here along the axial border of the sternocleidomastoid muscle. You can see here the platysma muscle. After that, we can see the medial border of the sternocleidomastoid.
You grasp per कहाँ गयो?
We are going to lift it up like that, and finally we can see here the carotid. Sorry.
तेरी का यहाँ को grasp per कहाँ गयो?
Jugular vein and
तेरी का नि गस पिस नि.
you can see the carotid sheath. This is carotid.
यही छ गस पिस जुन त केले दिनु यहाँ को grasp per थियो कसले लग्यो त नि यहाँ grasp per.
From this, we will go to.
हो?
Now we can also see the strap muscle.
ल यो दिनु न.
Omohyoid has the
गस पिस थियो नि च्यापेको हाम्रो.
hyoid head and it is going obliquely. So we can sometimes cut this muscle also, but this time we are preserving it. After carotid sheath, if we leave the carotid sheath, we can see the prevertebral fascia. This is the prevertebral fascia, and this venous pregus is dorsal venous pregus. And we mobilize it like this. I'll take the esophagus. The NG tube is already being inserted preoperatively, so it is very easier for us to palpate the esophagus. And now we are going to continue to anterior dissection. Okay. यसमा दिन्छ तिमी त्यताबाट देख्ला ल देखेछ यो चाहिँ esophagus-को लाइन चाहिँ ओके देखिसकेछ एन्टेरियर डिसेक्सन एन्टेरियरले खोल्नु एन्टेरियर खोलेपछि आउँछ हैन त एन्टेरियरले नै खोल्नु खोजेको यसरी फिङ्गरले डिभेलिङ Got it?
Check.
So we can say there we are dissecting the esophagus over the anterior boundary, medial boundary, in order to
check off microphone.
Feel was it? किन देख्यो र ऊ हुन्छ हो
पछाडी पछाडी हुन्छ एन्टेरियर
एन्टेरियर ऊ गरेर डिस्टेन्स रिकरेन्ट जान्छ फेरि कता हो कुन रहेछ
यो ऊ हो छ यसै व्यवस्था
मोबिलाइज भएको छैन एन्टेरियर
एन्टेरियरली भएको छ
एन्टेरियर गर्नु मोबिलाइज आउँदैन ओपीडीमा के हो भने सोधे सञ्जय
एकजना हामीले एक्जामिन गरेर
ए ल ल उसलाई भने धेरै उ नगरलाई जे छ त्यसलाई अर्को दिन बोलाइदिने भन्दै खालि सिम्बोलिक हामी छौँ भनेर भन्दैन सक्छ. So now we're trying to mobilize the esophagus. You can see here. So from posterior side, from lateral side, it has been well mobilized. So we are going to the anterior medial side, in between the trachea and the thyroid. भित्र छ र त्यो anomalyको कारणले पनि भित्र छ.
ठिक छ.
गस पनि खुलेर दिएन. होइन कुन पेन चाहिँ मलाई त्यति ठिक लागेन तपाईँको.
खै एकचोटि
सिजर थाम पर्छ यतातिर पनि रिटायर हो. सिजर यतातिर पनि रिटायर हो.
ट्र्याक्टर
सिजर दिनु सिजर सिजर राइट. ओके right. So I'm restricting with the seizures in order not using the thermal energy in order not to damage the recurrent laryngeal nerve. यताको बाटो राम्रो. Okay, so now we have taken out the cervical part of the esophagus, mobilize it. So now we will NG चाहिँ हेर त कटरी NG suction गर्दै तान्नुपर्छ. So now we are dividing the cervical part and we will make the staple anastomosis. So we can discard the excessive part of the esophagus later on. So I'm just incising it here. Can you hear? Am I audible, Dr. Robin? Kill. Dr. Robin? Action. Yeah. Suction गर्नु. Yeah, suction गर्दै जाऊ न. Suction निकाल्नु कसपछि. पहा खेलिदिनु पहिला हातले. उताबाट स्टोमक निकालेर निकाल्नु पर्ने थियो मिस्टेक गरेको.
हामीले त्यो कच्चा छिकेको
ठिकै छ. ओके यतिकै तान्दिनु.
झिकिसक्यो.
छोड त्यतिकै तान्दिनु भयो. छोड. सक्सन गर्दै निकाल्नु. धागो नम्बर 1 को यता एडिस दिनु. एडिस तान्नु. कटरी. So I clamp the esophagus here. Kotri. Clamp the esophagus. Divide the esophagus. Number 1 को try. अर्को पनि नम्बर 1 गरेर So I ligate the esophagus, the divided portion, and we can pull out this through the abdomen. Go closer. Arco, you like that. See that. PDS 40. Mosquito. Now show in the abdomen, Dr. Asis. So now this is the abdominal incision detector. We can show us the scale. So this is about 4 centimeter in length, incision site. So within the backpack.
Light bit retractor
Okay. So we'll pull out the stomach, and then look momentum. Okay. Take all this one. The colon, no, it's the colon. Retractor. The colon. They have the mass here, right?
The kids.
The momentum. Or deeper sense, son. Okay, this one. Or कोई एलिस बैक को कर को
बैक को किंता
बैक को
इंजीरियर लाइफ है बैक को
ये क्यों है यो हो रहा और तन रे okay go please कैमरा सफा कर देंगे so we have taken out whole of the specimen through the peritoneal cavity. So can you see it? Mosquito काट दो यहाँ काट दो हाँ केली tie over. So there are the lymph nodes here at the level 7 group. I can feel it. Tie.
Mosquito.
Bas pisa fagas pisa. Tie. See the level 7 group of the lymph nodes along the left gastric artery. Good. So show us the specimen. So we see the whole of the specimen has been delivered here. Right? This much. Okay, right?
Liver को attach with hand है
liver. Yeah. Yeah, we'll check. Before we used to use the ICG, but right now the ICG is not available in Nepal. So what we'll do, we'll just cut a piece of momentum here. This is the vessel here where where the site of the anastomosis. Then we can check the viability, I mean the bleeding or not. So there is a little bit short in the length. So we shall most there's some adhesion here, perhaps a detector to that. So I think it's all right. We can check the viability now. So the Oringer, you might have heard about Oringer. He is the pioneer in the transhiatal esophagectomy. See that he is the pioneer in the transhiatal esophagectomy. He says that what looks pink in the abdomen should look pink in the neck also. So, but whatever we have not till now taken it into the delivered into the neck. So this is the probable site of the anastomy. This is the cardia. So we'll take scale, sir. So this is the site of the tumor. Tumor is here. This part is the tumor. So we'll take about 5 centimeter from here. This one in the east direction. So this much we can discard. This one, this much of the okay. So at this side will be the probable site of the anastomosis. So we can hear this one. This is the vessel. We can inside the vessel here and look. What's the bleeding? So there is the bleeding. We can see there is the bleeding. So I think this is hopefully very viable part where we are going to anastomosis. Green. Green. Green.
Green stapler. Linear cutter. तर त्यो त्यहाँ गइसकेपछि बढिहाल्छ नि अन्त
यति यो नखलेको लेन्थ पनि होला नि भित्र
So we are trying to make not more than 4 centimeter in diameter the of the gastric conduit. Scale in the scale. Yeah.
Exactly 4 centimeters.
Yeah, so we'll bury a little bit, so it will be approximately 4 centimeter in the diameter of the gastric conduit. So now I'm going to fire the linear cutter. Arco.
ICG use गर्दा टाइमहरु कति पुग्नु हुन्छ भन्नु
25 seconds.
So यो ठीक छ
हाम्रो टार्गेट यहाँ हो
So Dr. Robin, so there was a question if we routinely before we used to use the ICG to check the viability in the neck. So what happened right now, it's not available, so we are not using it. But our target time was 45 seconds. Once you give by the intravenous injection, so we used to wait for 45 seconds, and that was the target time, and we used to divide at that section of that point of time. ठीक छ
चाहिन्छ एउटा
चाहिँ चाहिन्छ 60 को जेको भए पनि हुन्छ दिन यसो एसी खोल्दैन न गर्मी भयो पुग्छ जति
पनि पुग्छ सर
अलिक पाथेर गर्दा साह्रो यसलाई यहाँबाट एउटा छोटो आइदिनु पऱ्यो यो
त्यो छुट्याइदिनु अलि सजिलो लाग्छ है तन्केलाई
के लिदिनु त
के लिदिनु
केले भयो यहाँ हाम्रो छोटो छ उता दिनु यो त लिगा सुट दिँदैन त त्यो हार्मोनी
उल्टो दिनुभएको र
सर त्यो ट्युबको डायमिटरको बारेमा क्वेसन सोध्दै हुनुहुन्छ 4 सेन्टिमिटर एसेन्सियल हो कि अलिकति ठुलो बनाए पनि हुन्छ
So my personal opinion is that there are two schools of thought. Larger than 4 centimeter, I mean the whole stomach should be condemned. I do not prefer to use the whole stomach because this will not give the extra length in the neck. And the second issue with the whole stomach is that it will cause the respiratory compromise in the chest cavity because there may be some component of delayed gastric emptying, and the patient will have the stomach distension. So that will cause the lung compression. So therefore I do not use the whole stomach at all. And if you take the larger diameter, it will again cause the same problem. So the exact diameter should be 3.5 to 4 centimeter at the end. So that will have the enough length, so you can see the
specimen.
specimen. So this is the whole specimen. You can see here. So enough distance has been taken. The whole esophagus is excised. So we can excise a part of the esophagus which is remaining in the neck part also little bit. So I think this is the tumor-free margin, well excised. The lymph nodes you can visualize here, 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 and along the left gastric artery that we ligated here. So and this is here also lymph nodes. So we have done the two-field infracarinal lymphadenectomy for this particular group of the patient. Now after that, what we do, we bury the This one, this the suture line, staple line.
Monocyte.
Posterior monocyte. मलाई पनि त थाम पर्छ उता उता दिनु मलाई त
मलाई दिएन मोनोसिट दिएन
उताबाट हेल्प गर्नु
एकजनाले यहाँ हेल्प गर्नुपर्छ कि तल मसिलो अनि कन्टिन्युस तपाईले हेल्प गर्नुपर्छ है समाप्त पछाडि सिजर ल्याउनु किन
सिजर यसलाई पुट्ट निकाल्ने सिजर सुजर गर्नु सिजर So I make the interrupted stitch upper side because we don't know if the extra stomach has to be discarded or not before the anastomosis is done, and from below we'll make the continuous stitches. So just for few portion, I mean the 3 to 4 centimeter, will make the interrupted stitch, and from the downside we'll make the continuous stitch. So this is the PDS 40. We used here the 3 times linear cutter 100, so I think 200 plus 20 centimeter, 220 centimeter of the length of the linear cutter was used to staple the stomach to make the gastric conduit. And there was another question regarding the exact diameter of the gastric conduit. So if you make smaller diameter, narrower, like less than 3 centimeter, what happens? There is the probability of torsion of the stomach inside the chest cavity. This is one. And the gastric and the vascular compromise will be there. So the narrower tube is also not very good, quite narrow tube. Yeah. So exactly 3.4 to 4 centimeters is good for our patients. I mean, in Nepalese context, I have found that 3.4 to 4 centimeter in diameter is quite enough, quite good. Dr. Rasmi? Dr. Yogesh, is there somebody? Yes, sir. So is there any problem with you? I mean in the during anesthesia? So Dr. Yogesh, Dr. Rasmi, Sumit and Kiran, they have performed very wonderful anesthesia here. We did not face any kind of problem during the surgery. And we'd like to ask our nurses also. Hamal madam? So did you face any problem during the surgery? Hamal madam is also saying it was perfect. The circulating nurse and the Namrata sister is here. So did you face any problem with the surgery? She said it's also good. And the scrub, the circulating nurse Raksha, have you any problem? It was okay. And Dharma sir, where is Dharma sir? Dharma sir, have you any problem? No. So everything was perfect, I think. The whole BPKMCH team is here. So thanks to all of them, because it's because of them that we have reached this to this step, to this level. I think it's very good, Dr. Robin, that you should have a good working environment, good team, which I am proud of. That in BPKMCH we have got a very good team, not only in the operating room but also the management support is there. Yes, Dr. Manoj?
Yes, sir.
So I would like to convey my sincere thanks to our administrative team, especially Chairman Sir, Dr. Sibaji Paudal, he is our Executive Director, Dr. Umesh Nepal, our Deputy Director, and whole Nursing Chief, Anita Devkota, and all of the OTA staff, all of the staff, and especially the IT team. They have helped us a lot. I think the transmission is quite good in the YouTube. But may not be the audio sound very good in the hall, but in the website it's very good. And I also think that this Nepalese Association of Surgical Gastroenterology is doing a wonderful job, because they have been arranging such seminars quite good. There was one seminar in the conference in last year in the Kathmandu. We enjoyed a lot. There was quite a number of educational sessions over there. And also today, I'm in hurry to listen to Dr. Mukunda and Dr. Narayan Belbase. They will have the wonderful talk today. So don't leave this. Whoever is there, the surgical faculty, please do not miss the wonderful talks by Dr. Mukunda and Dr. Narayan. So we'll finish the surgery, I think in time. So I think by 12 o'clock, what's the time it is?
Samadhan.
Can sir hear me?
Yeah, yeah.
Can Vinay hear me?
Yes, Robin. Yes,
Thank
Robin.
you, Dr. Vinay, for a wonderful surgery. I think we should have a big
Lunch.
round of applause for him.
Yeah, thank you very much. Thank you very much.
Yeah, I think the audience is now anxious for lunch and they'll be coming back after that.
Sure. And
Wonderful surgery. Vinay,
thank you very much.
Great to see you again and again.
Thank you very much. Thank you very much. Okay. Bye bye. ल ठिक छ भने लन्च खाने बेला भइसक्यो
यसलाई काट्दैन
छोडिदिएर के
यो पनि काट्दिनु यो पनि
Second to prevent the
युट्युबमा त लाइभ नै भइरहेछ नि सर
Pardon?
steps taken to prevent the rotation.
So you will see how we prefer what we do to prevent the rotation. So this, can you show here, focus here? So this is the left side where the omentum and gastroepiploic arch is lying. This is the right side, this is along the lesser curvature. So what we routinely do, so this is the probable site of the anastomosis. I take this one with one stitch, and if there is the omentum, silk 20.
20 silk.
What?
लास्टमा हामीले क्यामेरा पनि हालेर हेर्छौँ कन्फर्म गर्छौँ हैन सर
हजुर के भन्यो
क्यामेराले पनि यहाँ हेरेर कन्फर्म गर्न मिल्छ अहिले
Give me. So to prevent the rotation, what we do, this is the probable site of the anastomosis. So I take one stitch here, which we do not tie. This one, we take a piece of omentum, this one, along with it, so that we can wrap the anastomosis with the piece of omentum, right? Chodo, are you mosquito? Okay, samata. And do it samata. Cut.
सिजरले काट्दैन.
And this side also, we take the another bite here, which we ligate here. There is no no knot, but here we keep a knot. So this is just to confirm that this knot is to the left, to the right side.
Right side.
Right side, towards Dr. Sagar, and the without knot is to the left side. So this is somehow will tell us that we are not making the rotation. Cut. Number 1 को tie.
1 को tie.
इसीलिए वजह से. Hold it, please. Bye. Jelly. So now we'll pull the stomach up into the neck. यो मलाई स्टिचै दिनु भएन कि पीडीएस दिनु न एउटा काम पर्छ उता मस्किटो
यसो छ सरी
यता पनि ल्याङ्गे ब्याग दिनु न